Good evening, Dr. Hussain. Thank you very much for taking the time to join us.
Thank you for the opportunity. It's my pleasure.
Not at all. As Priya had indicated, what we're interested in hearing from you this evening is when you think patients should start to involve a medical oncologist in their treatment, and I recognize that you may have a slightly different perspective than some in the urology community. Also, to talk about what patients can do to maximize the quality of life as well as the extent of that life, because clearly patients can be on treatment for advanced prostate cancer not just for months but for many years, and the quality of their life is therefore very important over a considerable period of time. So with that, I'll hand over to you to talk about the things that are of interest to you in that area, and also some of the new learnings that you may have come up with after the genitourinary cancer meeting that was completed recently.
Absolutely. Thank you very much, Mike, and it's really a pleasure to be here. So let me begin with the issue of when to start involving a medical oncologist in the process of care and in the process of helping with the decision-making for the patients. I'm going to probably begin by saying that, first of all, I'm a medical oncologist, so my views could be interpreted as biased. However, I do think that there is room for a medical oncologist opinion at every step in the process, starting from a diagnosis of a cancer that is not irrelevant type of cancer. So to give you an example, I recently saw a gentleman who is 58 who has prostate cancer, a Gleason 7. He has no other health issues, and he saw a radiation oncologist, and he saw a surgeon, and he obviously got two different opinions. So while they told him you have an excellent chance of cure, you are treatable, each person preferred one treatment over the other. This is when he decided to come to see a medical oncologist for the discussion. I certainly would argue that patients who have high-risk local disease, so bulky disease in the prostate or a high Gleason score, where there is the issue of balancing the local, regional, and systemic control, I do believe that medical oncologists should be involved in helping the patients with the decisions, going over what we know and what is the data from well-done clinical trials and so on. So that would be from one end of the spectrum. Is it a must at that level? Not necessarily, but I do think it could be helpful. I do think that when patients with prostate cancer have relapsed after local treatment with either a rising PSA and no evidence of obvious cancer spread by scans, or subsequently who develop metastatic disease, or those who right now have new metastatic disease, I do think they should consult with medical oncologists, and partly because the options of treatments can be quite different nowadays, and we can talk about that perhaps later. And there are issues of what is the appropriate amount of imaging, what is the appropriate treatment if one has just a rising PSA versus real metastatic disease. If a person has metastatic disease, do they have options of clinical trials, and should they be considering chemotherapy early versus not, and so on. I also think that there are a fair number of patients who are treated primarily by the urologists who, for whatever reason, are on hormone treatment and now have disease progression either by PSA going up or by cancer getting worse in the scan. This is really an area where I do believe that they are, in my opinion, better off with medical oncology because of the potential options coming to them and the different management issues that are going to be necessary. And this kind of ties nicely, Mike, with the second question, which is the quality of life. And as you know, quality of life is different for each person. What might be bothersome for one person is not at all bothersome to another person. And depending on the disease setting, the bother becomes relative. So someone who has no symptoms whatsoever from their disease, let's say just a rising PSA, and somehow end up on hormone treatment, that treatment can cause more bother than someone who has metastatic disease, not because it's physically that much different, it's because the context is different, and the quality of life has to be looked at together within the context of risk and benefit from treatments and so on. I do think that from a patient perspective, the best quality of life can be made by better understanding of why someone is needing the treatment, so they can basically balance and understand the risk benefits from what the decision that they're going to make jointly with their physician with regarding the treatment. Also understanding the objectives from the treatment, and also trying proactively as much as possible to maintain a relatively, as much as possible, healthy lifestyle, so that it can balance the potential downsides of different treatments that might be prescribed for them. I also think that it is very important for the patients to be proactive in asking their physicians about what they may have in terms of services available at the institution or locally to help with different issues that might surface as it relates to the treatment. There is the other factor, which is what we call the survivorship factor. So, as you know, the vast majority of patients with prostate cancer are luckily nowadays are diagnosed with localized disease, which is highly curable. Highly curable with local treatments. Those treatments do leave the patient with residual effects, whether it's incontinence, whether it's impotence, or sort of radiation-related issues and things like that. So most of the institutions, and certainly at our place, we do have actually a specialized clinic that is the survivorship clinic, which is focused on aspects of maintaining and maximizing quality of life for patients as it relates to their symptoms, whether it's physical or mental. And I would say to my patients in general, do not hesitate to ask, and do not be embarrassed to request help in that regard. Now, one more thing I would say is that for patients who have advanced prostate cancer, that is metastatic or end-stage castration-resistant disease, we also have palliative care symptom management services available that can work with the managing physicians to try to optimize either the disease-related symptoms or side effects related to the cancer itself. And again, these services are available, and they both what I call mind and body type focused services that can be instituted. And I do think that it makes a huge difference from the perspective of the everyday life of our patients.
Thank you. That's very helpful. Now, perhaps you'd like to talk to us a little bit about any new data that you felt came out of the GU Oncology meeting.
Oh, certainly. So perhaps I can preface this by saying that research is what will cure cancer. And in the business we are in, our hope is ultimately to reach the metric of cure. In the process, obviously, research is what's going to lead to the discovery of things that could help us either diagnose the cancer much earlier, where we can now cure it with local treatments, or discover different interventions, whether it's medications, radiation, imaging, that will help us obviously control the cancer and prolong life and hopefully reduce death from the advanced prostate cancer. So we just came back from, and so from my perspective, I'm sorry, let me back off here. So I do think I am I guess I would like to encourage patients when they are consulting with their doctors to ask about what clinical trial is available for me, doctor, and carefully consider the options and make a decision that's informed based on what is suitable for the patient's situation. So please ask all the time and look into possibilities because, as I tell my patients, every drug we have in the market today started as an experimental drug at some point. And so I think that's very critical. I do think there are several very interesting things that I think I came out with from our recent genitourinary ASCO meeting that happened in the last month. I do think one of the areas that are interesting is, and we are getting a lot of focus on, is improved imaging. As you know, when we diagnose cancer, one of the first steps in evaluating how we're gonna manage that cancer, the first steps that we need to evaluate is how big is this cancer and where has it gone. And so there's a fair amount of focus on imaging, whether it's molecular imaging, MRI, PET-based imaging, and so on. And so one of the very interesting projects was reported as a preliminary, obviously, very early phase, is looking at enhanced MRI imaging for lymph node staging in prostate cancer, which I thought was very interesting because clearly we know that prostate cancer, when it spreads, either goes through the blood vessels and settles in the bone that way or other organs, or it goes through the lymphatic system and settles in the lymph nodes. And so this is a technology that allows for a priori assessment potentially of the extent of the cancer prior to intervening with surgery or radiation so that better planning can be done. So I thought that was an interesting technology and a contrast, a special kind of contrast-enhanced agent that was being developed at the NCI. Another thing that I thought was very interesting was all of you must have heard, and I don't know if you're familiar with the report that came out of the Hopkins group regarding the androgen receptor splice variant 7, which is the androgen receptor is essentially the window or the door that that where the male hormone testosterone or the androgens will actually go into the cell through and trigger all kinds of stimulation of the cell to grow and divide. And so we know that in patients with castration-resistant prostate cancer, which means they have already seen hormone treatment to suppress their testis from making the male hormone, and where their cancer begins to grow, we know that we have, at least right now, 2 drugs that are still targeting the androgen pathway and the androgen receptor pathway, specifically abiraterone and enzalutamide. We know that if you take 100 patients up front, it's about half, roughly, that will respond, their cancers will respond to the treatment. And so it's been very peculiar as to why is it some cancers don't respond, and what is it about these cancers that, you know, are not responding, and can we predict who is not likely to respond so that we can spare them the physical and monetary cost of these drugs. And so the group looked at this particular variant in the setting of patients undergoing abiraterone or enzalutamide, and demonstrated that in a preliminary manner that those who express this particular alteration on the androgen receptor, they are not likely to respond to the hormonal agents. Interestingly, at the GU ASCO, Dr. Antonarakis reported that they looked at whether the patients who express this particular alteration, for short I'm going to call it ARV7, whether they will respond to chemotherapy. And interestingly, it didn't matter. So Taxotere or docetaxel, in fact, was not, there was similar activity for docetaxel, irrespective of what the AR variant status is, which I think is an important observation, because we're all beginning to see that patients who had, let's say, abiraterone up front seem to not respond as well to enzalutamide afterwards and so on. And this may be because of different resistant things that the cancer, makes. At least in the setting of this particular variant, it doesn't appear to be prohibitive, and it suggests perhaps that patients should not be delaying chemotherapy too much. Another observation that I thought was very interesting, and as you know, the immune treatments are really very interesting treatments across multiple tumors, and trying to help the body overcome the effect of overcome the resistance to cancer by trying to arm its immune system to fight the cancer is an area of very, very exciting, is going through a very exciting time. And the checkpoint inhibitors, as we call them, and you might have heard about the PD-L1 type agents, inhibitors, are a very exciting research area. And the issue is whether these types of agents and others that are trying to arm the immune system to fight the cancer are going to somehow transform how we do things in prostate cancer or not. And so there was a report on a trial that's looking at an immune agent called Prostate, and together with another agent called ipilimumab, and the data from that one, again, these are very preliminary. I should caution everyone, very preliminary, but the data looks very, very interesting in terms of the efficacy and in terms of how long people lived when actually both treatments were combined together. So I would say stay tuned, because in fact there are trials that are being planned in those areas. Another area that I thought was very interesting is and this is unfortunately is, and let me finish the good news. Another area that I thought was interesting is the fact that there was some preliminary data reported on the combination from an expansion or open access type phase of a trial with radium, where they looked at whether patients who, say, were on enzalutamide or abiraterone and got radium as part of the expanded access, did they do well, and was there any kind of bad signal, was it safe to do, and so on. And so what's interesting is that there's a clear signal of safety and well-tolerated type combination treatment, and so the preliminary data on outcomes also looks rather interesting. And so, in fact, there are, I believe, now trials looking at combining these agents with the radium to see how that treatment is going to, whether it's going to result in improved outcomes overall. And then finally, on the positive front end, I want to mention that there are a slew of agents that are coming to the clinic in the form of clinical trials, looking at what I would call smarter hormonal pills, so to speak. And there was an interesting observation from a group based on preclinical work, so laboratory work, on a drug called ODM-204, which is one of those agents has the same kind of effect like abiraterone in some way in terms of how it works or the mechanism of action, together with inhibiting the androgen receptor and so on. So I would say stay tuned, because more and more smarter hormonal drugs are going to come to be tested. Now, whether they're better than what we have right now remains to be seen, but I do think that some of them may turn out to be quite a bit better. Now, finally, I want to end with a couple of notes, and one of them is on a drug that is I have been involved in working with in the early phases of it, is a drug called cabozantinib, a drug that we reported a couple of years ago based on observations from us and others, suggesting a very promising level of anti-cancer effect. Unfortunately, this drug has gone into phase 3 trials and was compared to prednisone. And the trial, phase 3 trials, these are trials that are generally quite large, and they are looking at an outcome of survival. Does it prolong life? And unfortunately, this drug failed in the population that was tested. It was tested in, which is men with metastatic castration-resistant prostate cancer. It failed to show a survival advantage, which highlights the importance of doing these types of trials and not jumping into conclusions from early phase type trials where there is a lot of promise. Promise is important, but it's our obligation to prove that, in fact, we are helping patients and we are not subjecting them to harmful agents without an advantage with regard to survival. So, unfortunately, that trial results were not positive for survival. There were some hint of activity and delaying cancer progression, not enough. And finally, I want to make a comment, and I don't know, I can combine it with my comments, Mike, on chemotherapy in patients with metastatic disease. This is the GTUG update. Do you prefer if I hold off right now, or should we do that? Because I see a question possibly on the CHAARTED trial.
Right. Let me ask a couple of questions, and then maybe we can come back to that. On the very simplest level, obviously a lot of patients probably arrive in your office and they tell you that they're on all sorts of supplements and things like that, as well as their hormonal or chemotherapy. What do you say to patients who come in with a long list of supplements like that they're taking, or other agents, where we really have no good data that tells us one way or another whether there is a benefit?
And you're absolutely correct. I also, so the supplement will take, I guess, two forms, is vitamins, and then I'm going to categorize it, the others under an other category. And what I would say is that there is really no objective data today that taking supplements of any kind beyond a healthy, balanced diet, and perhaps basic things if you feel that your diet is not, adequately supplementing you with, let's say, vitamin C or calcium or something, that there is no data to date that says any of the supplements, in fact, has a positive influence on the cancer or the outcome from the treatment. I will also go one step beyond and point out that, if anything, whenever we tested some of the vitamins like vitamin A or the supplements like selenium and others, there was, in fact, a harmful effect. And so just because something is natural, it does not make it safe. And I would caution patients, especially because some of the drugs that are oral agents may actually interact, either the supplements may cause something that will affect the drug in the body, or vice versa, where the level of the drug may go to a low level such that it becomes not effective, or may cause side effects. So I would encourage patients to, and I know there's all kinds of stuff on the internet. Just because it's in the internet, it doesn't make it the truth. And just because somebody swears it's true, it doesn't necessarily mean it's true. It's not proven to be true. So I would caution the patients in general, and I would encourage you very much to consult with your doctors, primary care and oncologists, regarding the safety and the wisdom in using some of these medications, some of these supplements. I also remind patients that a lot of the chemotherapy we use, by the way, is natural product. And so that doesn't necessarily mean it's safe. And a lot of things that are poisonous to humans are also natural products. So being careful is important.
Thank you. And so now I have a rather more complex question, and you might want to weave the answer to the CHAARTED trial into this.
Okay.
One of the things we saw from the CHAARTED trial was that you did not have to give prednisone along with the docetaxel. And one of the things that I have been thinking about is that in most of the trials that we have, in fact, I think all of the trials that we've been doing in late-stage cancer, prostate cancer, we are adding a new drug on top of standard hormonal therapy. And I'm seriously beginning to wonder whether that is always a good idea, because one is subjecting the patient to all the side effects of standard hormonal therapy, in addition to the new drug that one is adding. And yet, as you kind of alluded to earlier on, the patients often may be getting more side effects from the hormonal therapy than they are any survival benefit. And I'm just curious how you as a researcher are starting to think about how we move forward with trials that may help to resolve some of these issues.
Mike, this is an excellent question, and I have to tell you that it is complicated, and so you're absolutely correct. I'm not sure that we know from a biological perspective that what is the 100% correct answer. So you are absolutely correct that in CHAARTED there was a conscious choice not to add prednisone on top of everything else, aside from the use around the need of steroids around the time of chemotherapy, which is part of what is required from a safety perspective. And you are absolutely correct that in the castration-resistant disease, people keep adding prednisone or drugs to prednisone, for example, and therefore when the drug makes it and it goes into FDA approval, it is packaged with prednisone. So in this case, docetaxel or Taxotere is packaged with prednisone when given in castration-resistant disease. I'm going to give you my perspective, and this is not necessarily evidence-based, but rather experience-based. I do think that the disease context does matter, and it matters at two levels. One of them from the efficacy perspective, and then the other one is from the tolerance perspective. So in patients with advanced castration-resistant disease, I would argue that the reason prednisone was given in addition to Taxotere is because when the trials were done, specifically the sponsored trial, not the SWOG trial that I was part of, it's because the control arm had prednisone and you really didn't want to put your drug at a situation where you're going to lose. So you wanted to make sure that the arms are balanced with regard to, the other drug included, in this case, prednisone. Now I actually have a different perspective on it, in that biologically, if you think about it, patients who have castration-resistant disease historically, before we got all these fancy drugs, actually were getting treated with steroids. And biologically, we know that the glucocorticoid receptor and the effect on the adrenal gland and so on does result in anti-tumor effect in patients, and we all have our maybe not huge number, but over the years we all have had our groups of patients who, for whatever reason, are responding to steroids, whether prednisone, and generally in my case I use dexamethasone, and I actually have patients years out with castration-resistant disease with response. So I do think that one thing we need to think about in this disease, that one size does not fit all, and what we do in castration-resistant disease in terms of the regimen development does not have to be 100% mirror imaged in the hormone-sensitive disease. Hence, in the setting of the hormone-sensitive patients getting docetaxel or Taxotere together with their hormone treatment, when you're talking about a disease that is not resistant and a disease that is very responsive to castration, that the mileage obtained from adding steroids may not be there as opposed to the other setting. The other thing I want to mention is that in settings where you have bigger, a bulkier disease, while the steroids do have side effects, there is no question they do have some benefits that may not be huge anti-cancer effects for every patient, but rather energy, pain, appetite, and so on. So some of us actually resort to adding these medications selectively for some patients who may not be, let's say, on Taxotere or something like that. And clearly, with drugs like abiraterone, while people talk about it is safe to give without the prednisone, I will say from my, again, anecdotal observations on my patients, abiraterone appears to be quite well tolerated, and I wonder how much of that because of the prednisone being on board. So I don't know if this is a long answer to a short question, and I don't know if it answers your question.
Well, it answers some of it, and obviously we're not hoping to get perfect answers to everything tonight.